Hi, everyone. My name is Emma Guttman, and I'm really excited to be here delivering this lecture. I'm sad that I'm not there in person, but just think about the fact that I'm there in spirit. So very exciting times in general in atopic dermatitis, and particularly exciting time also in the space of JAK inhibitors and biomarkers in atopic dermatitis. My disclosures: I don't have any patents, ownership, or financial gain from any product. So atopic dermatitis is a disease that we see a lot, but it's important to remember that this is the most common inflammatory disease we have, and definitely the most common inflammatory skin disease. About 7% of the adults in the United States, around 15% of the children, up to a third will have moderate to severe disease. Still, the majority will have mild to moderate disease. And up to recently, we had a huge unmet need for better long-term disease control. So today I'll show you that the therapeutic drought is finally ending, including in the oral space. So how did we get to this very successful point in atopic dermatitis? And I consider the atopic dermatitis to be perhaps the most successful example of translational medicine we have in general, not only in dermatology. It all started with bench studies of pathogenesis that included biomarkers, both in skin and blood, that helped us narrow or formulate pathogenic hypotheses, followed by clinical trials targeting different pathways with targeted agents, including biomarkers that are really important, both skin and blood. And for each success story, we had multiple failures, allowing us to generate new treatments. And like I think in life in general, not only the successes, but even more importantly, the failures are so helpful to be able to allow us to frame pathogenic concepts and our therapeutic directions. So as we know, the original immune suppressants like cyclosporin, methotrexate, prednisone are very broad, right? They target everything in this map. T cells, B cells, any type of T cell or B cell you can imagine. And because of that, they are associated with multiple side effects, including infection risk that we need to consider now, particularly in the COVID-19 era. So we want to shy away from so broad immune suppressants to much more targeted treatments. And another important consideration is the idea that, on the other hand, atopic dermatitis is highly heterogeneous, right? It has a very wide spectrum of clinical phenotypes in children, and then based on ethnicity and age, there are multiple flavors to the disease. One will have higher Th17 activation, one will have higher Th1 activation, like chronic stage in European Americans. Children will have higher Th17, so do Asians. Patients of an African descent have Th2 and Th22. And of course, we have differences in the barrier polarization of these patients. Now, it's important to remember all these subtypes of atopic dermatitis share that robust Th2 activation, but different phenotypes may require additional cytokine targeting. And recently, we published a paper showing that patients with atopic dermatitis, since they were little children, have a different phenotype than those that we all see that start the onset of atopic dermatitis later in adulthood. And many times they also don't have other atopic comorbidities. So we found that the difference is that those that start in adulthood have a higher Th1 skewing, whereas those that start in childhood have higher skewing of Th2 and Th22 and Th17, and those that start in adulthood also have higher inflammatory burden in general in blood, as well as cardiovascular associated markers. Now, we also need to imagine that patients that have more than 10% body surface area in atopic dermatitis, their inflammation is more than skin deep. So what you see on the skin, those red lesions, it's also relevant to their blood inflammation. So they are having a very highly inflammatory phenotype, and you need to target the disease as a whole. Just targeting the skin will not help. So you need to target it systemically when patients have a widespread clinical disease. And that was also validated by population-based studies that showed that atopic dermatitis is associated in large population-based studies to cardiovascular disease. So remember, high morbidity in terms of widespread body surface area, you need to initiate a patient on systemics. So now we will focus on JAK inhibitors in this lecture. And JAK inhibitors are handy in atopic dermatitis because the disease is highly heterogeneous. It involves multiple immune pathways, including the Th2 pathway with IL-4, IL-13, but also the type 22 pathway with IL-22, the type 1 pathway with interferon gamma, and even the type 17 IL-23 with IL-17 and IL-23. And the differences, as we discussed, are based on age of patient, disease duration, ethnicity, and many other things. And JAK inhibitors target more than one cytokine pathway, and they can be quite handy for us when we consider treating the entire patient spectrum. So we have multiple JAK inhibitors, but I just want to refresh your memory that they target different pathways, and some target JAK1, some target JAK1, JAK2. Baricitinib not approved in the United States, but is approved in Europe for atopic dermatitis. Some target JAK3 for alopecia areata or TYK2, and so on. So now let's dive into the data. And this is the data with upadacitinib. That's a specific JAK1 inhibitor from AbbVie. And this is the phase 3 study, Measure Up 1. And it had also Measure Up 2, but here I'm showing you Measure Up 1. And here you see EASI-75 and validated IgA scores that are very high, right? EASI-75 approaching 80% at 16 weeks in the patients treated with a higher dose. That's a very high number. And the validated IgA around 60%. So you can really push the bar of efficacy with JAK inhibitor, evolving our treatment goals. And importantly, right, as treating physicians, we are asking ourselves, is that patient sustained long-term with a given drug? And pay attention that the answer is yes. This is the EASI-90 responses, so you really push the efficacy. EASI-90 is almost clear, right? You push it and pay attention that until week 52, the patients are sustaining in the blinded extension, they are sustaining their responses. And the same when you look at the validated IgA 0 or 1 score. So clear or almost clear, again, you are sustaining the responses with both doses. And also the NRS 0 or 1, so almost no each, is also sustained really until week 52. Now, with JAK inhibitors, we know that safety is of issue, right? It's a major issue for us to see what happens here in terms of safety. So I wanted to show you here safety of up to 4 years. And the first thing that strikes you when you look here, you don't see really more safety concerns at 4 years compared to 1 year. And that's good, right? So yes, we do see some safety issues at 1 year, some opportunistic infections, but pay attention to the low numbers. Serious infections, some herpes zoster, we know that we'll get that with a JAK inhibitor, some non-melanoma skin cancers, very, very small rate of a malignancy other than a non-melanoma skin cancer, and almost not existing MACE or major adverse cardiovascular events, and VTE. And pay attention that this is better than we would expect, right, with a JAK inhibitor, particularly when you look over time, up to 4 years. Now, this is integrated safety of upadacitinib across multiple indications that it's now available for. Atopic dermatitis is only one of them, but there are other indications such as RA, psoriatic arthritis, ankylosing spondylitis. So let's review how is atopic dermatitis faring with this. So patients with atopic dermatitis tend to be a little younger and healthier. And really you see very good safety in atopic dermatitis. What strikes you is that you actually see more zoster in atopic dermatitis. Zoster is seen more in atopic dermatitis, but otherwise you see a very good safety in atopic dermatitis besides the zoster. Zoster and some serious infections also you see in atopic dermatitis. Malignancy, pay attention, very, very low rate, the same with MACE and the same with VTEs. Now, this is a study that compared head-to-head upadacitinib versus dupilumab, both as monotherapy for 16 weeks. It's called Heads Up because it was a head-to-head study. The primary endpoint here is the week 16, but pay attention that at week 2, you see a big differentiation in terms of EASI-75. At week 16, dupilumab and upadacitinib are similar. There are 10 points of difference, but where do you see a big difference? In EASI-90 and EASI-100. Because upadacitinib will achieve the goal faster. It pushes the efficacy ceiling faster, and that's what you see. So if you have a patient that needs to go to a wedding, this is a very handy approach. Pay attention to the EASI-90 and EASI-100 here. So this is a study that we already presented before, not yet published, but presented in a meeting in which we performed the biomarker study of upadacitinib as compared to dupilumab study. The same study that I showed you. So this is the biomarker study from that a study that compared the head-to-head upadacitinib versus dupilumab. And let's see what are the differences here between the transcriptomic of upadacitinib and dupilumab. So upadacitinib is in blue, dupilumab is in purple, and immediately when you look here at week 2 and week 16, you immediately see that there are high significant rates when you evaluate the transcriptomic differences of upadacitinib and dupilumab. So upadacitinib managed to change the skin profile of patients with moderate to severe atopic dermatitis to a much larger extent. And pay attention that at week 16, we have 104% improvement with upadacitinib, only 62.9% improvement with dupilumab. So large difference, but at week 2, it's even larger, only 2% with dupilumab and 66.5% with upadacitinib. So again, you achieve it faster. I see dupilumab as a marathon runner, whereas upadacitinib is a sprinter. You are likely to get there with dupilumab, but it will take you a little bit more time, and you see it so well here. So you push the efficacy much, much faster and more robustly with upadacitinib earlier in the game. Now, when we want to zoom in at different immune pathways, we can do that. Here we are looking at markers that belong to Th2 pathways such as CCL17 and IL-13. Pay attention again to much more robust responses and earlier in the game in the upadacitinib arm. The same with the type 22 pathway markers such as IL-22, DS100, PA3, and of course the type 1 markers such as CXCL10 and CXCL11. Remember, the dupilumab doesn't really touch the type 1 responses. Now, what happens with the barrier? Barrier is modulated also to a larger extent by upadacitinib. Here we can see filagrin, filagrin 2, LCE5A, loricrin, and also negative regulators that we need to increase when we are targeting patients successfully with different treatments, and pay attention to larger increases in the patients treated with upadacitinib as compared to dupilumab. So, of course, you see larger effects in dupilumab and in upadacitinib. So definitely faster responses and larger by week 16. The results may be different if we evaluate it later, but this is a 16-week study. Now, what happens to AECs? This is something of interest to the allergy community, AECs over time. And pay attention here, we see much more deep reduction in the AECs over time with upadacitinib 30 milligrams. So this is the maximal dose of upadacitinib as compared to dupilumab. So it's significant with both, but the significance starts earlier with upadacitinib at 2 weeks, and it's much deeper over time. Now, what happens in serum to circulating proteins? The same trend, much earlier and deeper responses of type 1. You see here IL-2RA, IL-12B, IL-18, type 2, like IL-5RA, IL-13 in receptor 1, and type 22 with markers like elafin and others. What about safety? here is also a differentiation. We see more safety concerns, of course, with upadacitinib, with herpes zoster, serious infections. There was an opportunistic infection, and in dupilumab, we see conjunctivitis as expected. This is a patient of mine. She actually got successfully married, clear. She was very significantly involved with atopic dermatitis. Even cyclosporin did not work on her, but upadacitinib actually worked on her. She is up to this day managed with upadacitinib. She was also in one of the studies. And this is the study from Pfizer with Abrocitinib. That's yet another JAK inhibitor. And here I want to show you the same trend. You approach the maximal efficacy at week 16, but then you maintain it and even increase it a little bit with both doses, with both the 100 and 200, so the same trend. You reach your efficacy more or less at week 16, but maintain it over time. Here is for 96 weeks. Pay attention, IGA 0/1, EASI 75, very high responses, EASI 100, and peak pruritus NRS as well. What about safety? I like this analysis that separated patients by up to 65 years of age and over 65 years of age. And keep that in mind when you treat patients with JAK inhibitors. I myself do not treat patients over 60 and definitely not over 65 with JAK inhibitors, particularly after I've seen this data. Because pay attention, in young patients, you really have quite good safety. But the older you are and more than 65, that's where the trouble is. Pay attention that serious AEs, including AEs leading to discontinuation, are in those over 65, including serious infections and herpes zoster. And also, when you look at smoker or not smoker, VTEs and malignancies are more in smokers. So ask your patients whether they smoke. That's an important thing. And consider patients over 65 and give them JAK inhibitors only when you really have to. But in younger patients, on the other hand, you actually are expected to have quite good safety. And this is the mechanistic study that my lab collaborated on. It's now actually published in Allergy, and we have several others to come. So this is a mechanistic study of Abrocitinib. It's another JAK1 inhibitor, as I mentioned. And these are the clinical responses. The study was geared towards biomarkers. So the primary endpoint was not the efficacy, but pay attention to the very nice efficacy, and pay attention that in this study, placebo was really 0. And you can see a very nice dose response. So this was a biomarker study. Biomarkers were primary endpoint, quite a novel concept. And these were the biomarkers. And this is from our graphical abstract. Pay attention that there was a dose response and significance was achieved on these biomarkers. It was a 12-week study, not 16, very similar to the clinical trial. And pay attention that here we have many more immune pathways that are downregulated with treatment, including Th2, Th22, and Th1. And also we have increases in barrier molecules. So like I told you, JAK inhibitors can be handy when you really want to target the entire disease spectrum. Because remember, when you target with type 2 targeting agents, you are usually not decreasing so well type 1 biomarkers. And here, let's move ahead and also evaluate how tape strips can help us evaluate biomarkers at baseline and with the clinical trial. So why tape strips? Because it is painful to do biopsies. Biopsies are scarring, they are prone to infection, and they're not feasible really for longitudinal trials and clinical trials. And also in pediatric population, it's really tough. So we really spearheaded an approach of tape strips. Others used it too, but we modified it and adapted it a little bit differently. And these are the tape strips. You do them multiple times, you apply pressure, and we now do that in many, many clinical trials, and they're really helping us identify biomarkers of response. And we did that in this study that I just showed you, the biopsy data of the primary endpoint. And let's see what happens in tape strips. So the same study design, 12 weeks, placebo, Abrocitinib 100, Abrocitinib 200, And we took tape strips from lesional and non-lesional skin. We presented it at the Inflammatory Skin Disease Summit and at the EADV. It's not yet published. And the plus of tape strips is that you can do many more time points, and you can do both lesional and non-lesional. So let's see what happens. So in placebo, not much is going on early, but in abrocitinib, already you see a shift from red to blue and blue to red. And let's quantify this shift. So the zero line is the non-lesional skin. And here I'm showing you in red and blue how we are able to get towards the non-lesional in both the upregulated genes and the downregulated genes. And pay attention that with abrocitinib 200, you really are doing it, right? At both week 4 and more at week 12. Abrocitinib 100 also is improving, not so much happening in placebo. Now let's zoom in to the genes that are modulated with abrocitinib. So we see multiple type 2 genes, such as, the ones we like to see for atopic dermatitis: CCL17 TARC, CCL22, CCR4, AX40, which is TNF RSF4, AX40 ligand, TNF-SF4, IL-13, IL-31, the EAT cytokine, and many, many others. What about some barrier genes? Barrier genes we want to see upregulated, right? And we do. Pay attention to many significantly upregulated barrier genes, including many lipids, and tight junctions, gap junctions, and so on. And what about pruritus genes? We want to also see that we modulated pruritus-related genes. And here we did in a dose-dependent manners, genes like TRPV2, TRPV3, OSM, and many others that are linked with pruritus. Now here it's a word cloud presentation in which we put side by side our data from skin biopsies and the tape strips when you treat patients with abrocitinib. And the bottom line, we see that we modulated the disease very similarly in biopsies and in tape strips. There are differences, and in tape strips, look what pops up: IL-13, and we have many other important genes that you see modulated there: AX40 ligand, S100A8, and then you see barrier genes that are increased. So very important to do tape strips when we can, particularly that you can do that also in pediatric populations, and also when you want something to sample the skin for long term. In skin biopsies, you see, of course, that the S100s and lichenification markers are better, such as IL-22, because you sample the skin a little bit deeper. Now let's move on to topicals. Now we have topicals as well. This is ruxolitinib, that's a JAK1, JAK2 inhibitor for adolescents and adults with mild to moderate AD. Great data. We have it approved now in the United States, and I know it's coming to many countries. And now it's also moving into children. This is the data for 2 to 11 years old, and we are hoping that there will be approval. Also very, very nice data of both doses in children. And here is our biomarker data that we've done in collaboration with Insight on the ruxolitinib cream. And here we have tape strip biomarkers at non-lesional skin at baseline, lesional skin at baseline, and then day 8 lesional skin, and day 29 lesional skin. And what we see here in key atopic dermatitis biomarkers, they are modulated very early. Already at 8 days, you modulated the lesional skin biomarkers to the level of non-lesional skin. And this is for CCL17, that's TARC, IL-18, a very important biomarker, already goes down, but at day 29 here, it's like the non-lesional skin. CXCL10 already at day 8 looks like non-lesional skin. CCL20 also is almost at non-lesional skin at 8 days. And IL-22 takes a little bit longer until day 29, and CXCL1 also at day 29 looks exactly like the non-lesional skin. So very exciting to see a topical that modulates so quickly the biomarkers in atopic dermatitis using non-lesional skin, and we can definitely do that in children, evaluate long-term, and this is also done using the Olink platform. So this is a proteomic analysis, and we can do proteomic and transcriptomic in tape strips. So with that, I'm thanking you so much. You can imagine that it takes a real village to do a meaningful science, both in clinical trials and biomarkers. And we are really excited to make a difference in the lives of our patients and share it with you. Thank you so much on behalf of the entire department at Mount Sinai. Thank you.